Grace, I just sent you the link.
Okay, this is occupational therapy, right?
Yes.
All right, let me get there. Occupational Therapy Advisory Committee. July 14th, okay. There's the link. Give it to me. I'm sorry, I talk to myself when I'm working. Save. Publish. Let me go verify it's there. Advisory committees. Occupational therapy. July. Let me click it. Make sure it takes me there. We're in. We're good.
Grace, did you say we're good?
I did.
Okay, thank you.
Okay.
Second.
Morning. We ready to roll, Dr. Van?
Yes,
Yep,
I
you're
really
all
are.
good.
I'm gonna also bring in the two people that you invited. They're joining us now.
Is it Kristen and who else?
Marie.
Gotcha. Thank you. Ingrid, I'll get you her name. McLaughlin.
McLaughlin.
Yeah, McLaughlin, I think.
And she's also AOTA State Affairs.
No, she's the president of the Louisiana Hand Therapy Association.
Okay.
I'll get that to you though officially.
Ms. Darby, I believe you can begin, and as soon as I'm given the opportunity to share the screen, I'll put the agenda up for everybody to see.
Okay, thank you. I just got a message that Kristen will log in under the right link. So I'll go ahead and get started. We're going to call it to order a meeting of the Louisiana State Board of Medical Examiners Occupational Therapy Advisory Committee pursuant to lawful notice is duly convened and called to order at 10:08 Friday, July 14th, 2023 via Zoom virtual video. Please note any comments by the public are welcome and can be emailed to public comments at lsbme.gov. Change something real quick. Dr. Van, please confirm that you verified the identity of all the tele and video conference participants.
Yes, ma'am, we have, and I just want to make sure everybody can read the agenda. If they can't, please let me know and I'll adjust it.
Okay, thank you. And is the sound clear and audible to the public and those on the tele and video conference?
Yes, ma'am.
Okay. All additions to the executive or public agenda must be made presently, as we will no longer make additions to the agenda after the close of the public session. Quickly to review the mission of OTAC is ultimately to protect the public, that is the consumers of occupational therapy, by regulating competent practice and upholding the standards set forth by the governing rules and regulations. We have the following members present: myself, Darby Philibert, Ingrid Frank, the Vice Chair, Brenda Martin, Kelly Brandon, Carolyn Murphy, Raylena Cook. We have Kimberly Solaria is out. Is Amy joined us?
I'm on the call in, but I can't get in. It's Amy. I can't get into the actual meeting for some reason.
Okay,
Amy, I can resend you the link. Give me
Okay.
just a
Okay,
minute.
thank you. It just keeps spinning and it won't let me in. And I've been trying since like 10 minutes before the meeting started. And I was thinking, well, maybe it needs to wait till 10. So I've been trying. I'm sorry.
no, that's
Right.
okay. I just see your
Thanks
text.
for your
That's all.
effort, Amy.
And then we also have Glenn Wallace, who will be leaving at noon, correct, Glenn? I think that's correct. Okay, we also have Dr. Vincent Collada, the Executive Director, Olivia Pilong, the Executive Program Specialist. Is Jacinta with us today as well? Can't see.
No, ma'am.
Okay.
I'm on here.
I'm
you are.
sorry. I apologize. Forgive me.
Hello, and what about Tracy?
I'm here.
Okay, great. Thanks, Tracy. Okay. We also have two guests today. We have Kristen Neville, the AOTA State Affairs representative, and Marie McLaughlin, who is a certified hand therapist and president of the Hand Therapist of LA for Louisiana OT Association. Ingrid, you have confirmed a quorum, correct?
Right.
Thank you. Okay, the first item on the agenda would be the approval of the minutes from the meeting on June 9th, 2023. People can look at that, and then we can have a motion to accept the minutes as written, or unless anyone has any edits.
Well, I wrote them, but I'll motion to accept.
Okay, I didn't know if somebody was like, I'm happy to second them. All in favor?
Aye.
Aye.
Anyone opposed? And anyone abstain? Okay, any public comment, Dr. Van, for the minutes for the last meeting?
Not at this time.
Okay, the next item, with an email, I'm gonna try to put after the rules and regs, so if we can look at the rules and regs with our guest here today. Thank y'all both for coming. And Ingrid and the committee, thank y'all for completing the OT and OTA supervision guidelines last month without me. I know that was a huge hurdle to complete. So the next section that we really need to talk about is sort of twofold. One is adding any information about physical agent modalities. So that's usually embedded in the rules and definitions of OT, but for us would be section 1903, or possibly the intervention process. Sometimes it's mentioned, which would be section 4913, or we can make our own definition, but it is not previously mentioned in our rules. So that is something that we're going to have to think about, and just really not explained in detail. It's usually just mentioned as part of the intervention process, as like a preparatory to the intervention. So the other thing that is pressing and that is sort of the next big hurdle would be the dry needling. So basically what I did is Kristen had sent me the list outlined by states of all the physical agent modalities sections, and I highlighted the states that had dry needling in it, which is not many. It was just Mississippi, Tennessee, and Wyoming. And so I took those and made up a draft, got some input from Randall Alford, Mark Mullet, and Marie, and then just wanted us to have a starting point. So this is obviously not set in stone, definitely up for discussion, but wanted to go through it, want to hear what Kristen has to say from the AOTA standpoint, and trying to remember that we're being general enough so that we have some flexibility, but specific enough to keep the consumer safe. Kristen, do you have anything? Welcome and thanks for coming.
Sure. Thank you for the inclusion in the discussion. I don't have much to add. I'm just curious about what your feedback is. This is the first I'm seeing your draft, so like I said, I'm just curious about the conversation. I think, our position, as of April, as I know, I shared the document that we put out on interventions to support occupations that says that dry needling is within the OT scope. Doesn't go into a lot of detail. That's basically all it says. It doesn't say anything about training or define what dry needling is. So I think comparing what other states did is a good first step, but that's really all. I don't have much else to comment on, but I'm glad to answer any questions if anyone has any. Do my best anyway.
Okay, great. I'm sorry, I thought I had sent you the draft. My apologies. It's here. Would you like for me to send it to you real quick while we discuss it?
If you can, if not, after the meeting's fine. No worries.
Okay. Great. So basically, hopefully everybody's had a second to read it, but we'll just kind of go through. I'm kind of thinking, and y'all give me your input. Dr. Van, you have a question?
I just wanted to ask one question as you design where you're going to put this. Eventually, I imagine that this will become part of the core competencies of the newer trainees that come out into practice. Right now, it is not. And maybe what we ought to be thinking about is keeping this separate until it becomes common core practice. And I guess I'll use the example in gynecology. When Dr. Collada trained, there was no such thing as robotic hysterectomies. By the end of my career, I had taken robotic hysterectomy courses, and I probably did 95% of my hysterectomies by robot. And I think so this will evolve, but there's a certain group of OTs that have never been trained on this. And so it has to be a new modality for them, but it has to be recognized as that maybe in 4 or 5 years, this will be core competency for everybody that finishes. So I think the key here is maybe this should be non-core competency training, and then we can always amend that section as we come to that kind of situation with other things, whatever they may be. But that's just a thought for y'all to kick out, and I wanted to share that with you because we face that in medicine all the time.
I guess it's a question for the guys who are at the universities. Like, do y'all see this as upcoming training within school? I know PT students are already getting it in school and coming out when they graduate as able to practice it. What are y'all's thoughts?
We have not begun anything like that for OT school. So I think that it's going to be a outside of school post-graduation training for a while here at LSU.
Yeah, for us too.
Okay. Yeah, I mean, we really haven't talked about where in the document that this is going because we don't really have a physical agent modality section, and I don't really want to get into that because, naming every little one and then every time something comes up, it'll change. Dr. Van?
No, I'm fine. Again, I'm sorry, I thought I had lowered my hand. Please forgive me.
Oh,
I
that's
just want to
okay.
make sure we keep this in such a way that whenever that comes about, long after I'm gone, perhaps, or long after there's a new committee, Ingrid and the people will be teaching this as core competency in 5 or 6 years. And it'll be time to take this out of special training, and then everybody, unless, we have a sunset on people. But again, think about it in that there's some people that may never get this, some people that will always do this. And I think we just have to continue to figure out a way to address all of the types of OT practice that exist in the state.
Okay. I do know that some of the states have it separate on their website, like it's not part of the rules and regs, it looks like. And Kristen can I see that you have your hand up. Do you have a comment about that or something else?
Well, the only thing I was gonna say, was I agree with Dr. Van. I don't know about 4 to 5 years if it'll be that quickly, but you know, who knows? Maybe it will be part of the general education. But when we were discussing this, when the RA came to us and said, set up a task group to look at dry needling again, the task group pretty much agreed this was not an entry level intervention that folks just out of school should be doing. And that's why you're requiring an additional amount of training above and beyond what you require for your license, which is fine. And that's what most states do. So I just want to caution everyone that we always thought of it as not something entry level. I know there are some states that even don't allow OTAs to do it. I think maybe Tennessee might be one of them. So, you know, maybe at some point, like Dr. Van said, it will become part of, you know, education that everyone gets. But, you know, I just wanted to make that clear that we did not consider it an entry level thing. In terms of what you were asking, Darby, about, yes, some state licensing boards that haven't adopted regulations, they'll, like the Nevada OT board just has a policy in place that says it's not within the scope. Some states have approached it that way. I think there might be 1 or 2 that have said it is, you know, when someone goes to the board and says, is this within the scope? They'll come back to them and say, just like many other interventions, you need to make sure it's not explicitly addressed in the scope, but it's not explicitly disallowed. So you just need to make sure that you have appropriate training and you're able to provide it safely to patients. You know, my phrase that I always keep in mind is just because you can doesn't mean you should. You really need to make sure that you're competent to do this before you provide it to patients. So that was it. That was all I had to say. Thank you.
Okay, great. So if y'all just want to look through this, I don't know if maybe, Ingrid, do you think it would be better if you pull it up and that way if we make changes that you can make the edits as we go, like we do with the rules, or Dr. Van, would you be okay with that? So we can just
I don't care.
I'm not sure I have this as a Word doc unless you did. Did you send it to me?
I
At
did.
some
Do you need me to resend it real quick?
if you did already send it to me, then I do have it. I just gotta find it.
Okay. And Kristen, I just sent it to you too. So it's just, I think it's called proposed dry needling.
I got it. Thank you, Darby.
Oh, you're welcome.
Yeah,
Much
I do
appreciated.
have it also, Darby. So if somebody shares the screen with me, I will be able
Ingrid, you
to.
can share.
Okay. Great.
Dr. Van, I can't remember the gentleman's name that was on 2 meetings ago that had a lot of questions about dry needling. Do you know if he has anything specific questions for Kristen or
No, I don't, he didn't attend, but I will
Okay.
go ahead and make sure that he gets a chance to see whatever you document, and, you know,
okay.
we can talk about it as we finalize the whole rule package.
Yeah, I mean, I sent him the contact of Kristen and I also sent him Randall. I know that, you know, I connected them and I saw that he contacted Randall for sure, but I don't know if he asked any questions
Can
specifically.
everyone see the screen that I shared, that I've shared the draft?
Yes, we can see it.
Okay, great.
Okay, so basically, this, I kind of formatted it like it was going into the rules. So A would be dry needling is a skilled intervention that uses a thin filiform needle to penetrate the skin and stimulate underlying neural, muscular, and connective tissues for the management of neuromusculoskeletal conditions, pain, and movement impairment. So that's pretty common. It was in Tennessee's, but it's pretty standard in most of the states that have it, and everything I looked up as that being like the definition. As with other physical agent modalities in occupational therapy, dry needling is to be utilized in the therapeutic process to ultimately achieve improved function and therefore must not be applied as a standalone treatment. So that's something that we've constantly had a theme about, and it's not mentioned in all the other states, but I felt like it was super important to us to make it like well known that it is not a standalone treatment.
I like that.
Then dry needling. So some states do specifically just like parts like upper extremity, hand, but after some discussion with Randall and Mark, feel like if we just make it broad, then we can go from there. So one, in order to perform dry needling, an occupational therapist must obtain all of the educational instruction described in paragraphs 2A and 2B herein. The majority of the educational instruction must be obtained in person, allowing for self-study and partial online instruction. So the reason that the partial one and Randall and Mark and I kind of went back and forth is because even though the training is in person and obviously all the practice stuff is in person, there are some online components and a lot of the training of self-study that they have to do prior to going to the conferences. So it's not that they'll be trained technically online, because that's obviously not appropriate. But Randall's like, the way I had it worded before, he said there are a lot of the portions and even some of the tests that are online. So he didn't want us to like rule out that. Number two, mandatory training before performing dry needling to the upper limb. A practitioner must complete educational requirements in each of the following areas. A, instruction in each of the 4 areas listed herein, which are generally satisfied during the normal course of study in occupational therapy school. So we can leave that or take that out. Or continuing education from LOTA or AOTA approved continuing education provider. Neuromuscular, musculoskeletal and neuromuscular systems. Anatomical basis of pain mechanisms, chronic pain, referred pain, trigger points, and universal precaution. So that's pretty standard in the other states as well. B is where, you know, I don't know if we want to name a specific number, what that number is, and that's kind of where I needed Mark, I needed Randall and Marie of 24 hours of dry needling must include specific instruction in the upper limb defined as hand, wrist, elbow, shoulder girdle. The 24 hours must include instruction in each of the following 6 areas: technique, indications, contraindications, documentation, management of adverse effects, practical psychomotor competency, and occupational safety and health administration bloodborne pathogens protocol. So that tended to be standard on most of the continuing ed. It wasn't spelled out specifically on a lot of them that I looked at, but for the most part, that was part of it. And then each instructional course shall also specify what anatomical regions are included in the instruction and describe whether the course offers introductory or advanced instruction in dry needling, contain a practical examination and a written examination with a passing score, include an anatomical review for safety and effectiveness, and evidence-based instruction on the theory of dry needling. The next part is any occupational therapist to obtain the requisite 24 hours of instruction as described in paragraph 2B in another state or country must provide the same documentation to the board as prescribed in paragraph 2B that is required of a course provider. Not sure that we need to include that, but that was just something that I came across, you know, given in mind with the compact coming around, if that's important. The LOTA or its continuing education consultant must approve the occupational therapist dry needling coursework before the therapist can practice dry needling in the state. So it's about 50-50 about some people, some states require the board specifically to do it, like separate from licensing, but I didn't think that was something that was appropriate for us. But basically that's, you know, putting it on LOTA, which is our continuing education approval. Glenn, you have a question?
Yeah, so whenever you say a little bit higher, sorry, in 3 right there, when you say it must be, the documentation must be provided to the board, you mean OTAC or LOTA?
Well, that's kind of up. That's what I'm saying. Like,
because if LOTA is the one that is going to be handling, like, we approve this course, we don't approve this course, well, then I guess my opinion is that that's like if we don't say we approve the course, but yet we want copies of all of the paperwork from the things, then I don't know.
Right.
I don't know how
No,
you guys
I
want to
understand
do
you.
it.
I
Okay.
understand your question, but I mean, this is really here to expose y'all to sort of what's out there.
Sure.
Whether the board's going to do it, we're going to put all of it on LOTA. We can take that part out. This is really just a compilation of all the state's information for us to
Okay.
decide. But, keep that question in mind. We do need to address how we're going to do that, what it's going to look like, for sure.
Okay.
Thank you. Kristen?
Dr. Van had his hand up a little bit before me, so I'll
Oh,
defer to
sorry.
him. That's okay.
Go ahead, Kristen. Go ahead, please.
I
Oh,
looked
sure.
down and they were both up, so.
I'll be quick. Just since you touched on CE under the compact, I just wanted to remind everyone, the way that works is you only do CE in your home state where you have a license. In a state outside your home state where you have a compact privilege, you would not do CE to keep that privilege. So I just wanted to make sure that folks were aware that that's how that works. And so that it might inform your discussion on this.
Yeah, so the thing I feel like needed to be addressed or kind of popped up in my mind was that if somebody, had the training in another state or, say in Tennessee and they're doing it, like to come here, do we, they have to follow our rules and regs, obviously, but just to sort of remind them of that or to, do we want them to take an extra step to prove that meets our requirements?
Yeah, I mean, that's a good thing to discuss. And I mean, I can take that back to Chuck Wilmarth as a wrinkle to think about for the compact for folks who are doing. So yeah, and that's a good example you use, since Tennessee allows folks to do it. If they're doing it in Tennessee and they come here, they've got to follow your standards. But yeah, that's a good thing to find out how the training would work, this is training, not necessarily to renew your license. You need to show training that you're competent to do this intervention. It's something slightly different. So let me make a note of that and I'll find out how that might work. I mean, we may not know at this point because we're just kind of getting the compact started, but.
Yeah, and it goes back to kind of what Glenn said about so if someone, say from Mississippi, Tennessee, Wyoming, where they're able to practice, comes here and wants to do it, do we need them, do we want them to send the proof to us as the OTAC or to LOTA? Like that's, all those questions were kind of popping in my mind. Dr. Van?
Well, with all due respect, only the board grants the privilege, and the board is required to make sure there is current clinical competency at a base level. And as long as this is not part of core competencies out of training, and it's going to continue to be extra, we're going to have to figure out a way to document it. Right now in the IMLCC for Physicians Compact, we enforce a requirement and they allow the enforcement of states required clinical competencies and CME. For example, if an IMLCC person who resides in Washington State wants to write a prescription for a controlled and dangerous substance in Louisiana, they have to have taken our course. And if they haven't taken our course, they will not be able to do it because that's state law. It's required. If we make this we have specific areas of rules that are different in physicians' example, that, for example, pain and obesity treatments are have different sets of unique rules. And I think we would want to be able to at least verify the training as presented to the board for approval, whatever the board wants to approve. And then they have to present that as part of their ability to do this to protect the public. All we're interested in is protecting the public. And I don't know how you're going to do it if we're going to transfer that responsibility to LOTA. I'm a little uncomfortable with that. We have to think about that in great detail.
Yeah, I agree. So that's kind of why it was put in here for just us to think about like how we're gonna do this. So Okay, number 4, dry needling may only be performed by a licensed occupational therapist and may not be delegated to an occupational therapy assistant or support personnel. Again, some states allow the OTAs to do it, some don't. So that's something that we would need to discuss and decide. 5, an occupational therapist practicing dry needling must supply written documentation upon request by the board that substantiates appropriate training as required by this rule. Number 6, an occupational therapist performing dry needling in his or her practice must have informed consent for each patient that is maintained in the patient's chart/medical record. The patient must sign an informed consent form created by the therapist. The consent form must, at a minimum, clearly state the following information: risk and benefits, the occupational therapist level of education and training, and potential side effects. Number 7, when dry needling is performed, the occupational therapist must document in the patient's daily encounter/procedure note. The note shall indicate how the patient tolerated the intervention, as well as the outcome of the intervention, including any adverse reactions, events that occurred, if any. Number 8, practicing therapeutic dry needling without compliance with this requirement constitutes unprofessional conduct and subjects a license to appropriate discipline by the board and its agent. So one of the reasons that number 8, the therapeutic dry needling, is in italics, some states refer to this as TDN and use that throughout their statements and their rules, and then some just refer to it as dry needling. So I don't know if Kristen knows, or maybe Marie knows, like what's the appropriate, trendy, I don't know, but I just saw that and I don't really know what the appropriate term is or how, if it matters.
I missed that too, Darby. So you picked up on something I didn't pick up on. My best guess, just off the top of my head, is you're providing dry needling in an OT context. So they're calling it therapeutic to kind of differentiate it from if a PT is providing it or a chiropractor, or I know in Maryland, athletic trainers are doing it. So maybe it's just to differentiate it from someone else providing it. But that's a good question.
Yeah, so I left it in for us to discuss, just, because I wasn't sure and I didn't want to make the decision. And then that last point, I've already gotten clarification. That's included in Mississippi and maybe Wyoming, and that is being taken out in most of the states because that was differentiating it from acupuncture. So Randall and Mark felt like that wasn't appropriate to put in there. Dr.
I was
Mann?
going to say real quick, just from my knowledge of it, is that it was marketing and maybe like you're saying for each profession, but I know the PTs in Louisiana just say dry needling. Because you can also say functional dry needling and therapeutic, and so, but the PTs just say dry needling.
Generally, it's just called dry needling. That's the first time it came to my attention that someone calls it dry needling. Like I said, I didn't even know, or therapeutic dry needling. I didn't notice that.
Mm-hmm.
But yeah, very, very generally speaking, it's just dry needling. But it's a good point to raise.
I'm going to come back to that, Marie. Dr. Van, do you have a question?
Yeah, how are you going to handle? It's one thing if, for example, in an institution where OT is practicing and they do the dry needling, if there's a complication, there's the availability of sending them to the emergency room, getting a consultant physician. But what about the standalone occupational therapy clinic? That should there be some mechanism built into the rules that demands there is a mechanism for treating complications and transfer agreements to handle such? Because we don't have physician supervision here, and it's going to be done in your own in the private offices perhaps. And if they do get a complication where they have an aberrant vessel that starts bleeding or something like that, who's going to handle that and how will it be managed?
Yeah, I mean, I didn't see anything, nothing to my knowledge was ever addressed in any of the other states. I mean, I would assume that it would just be handled for clinic, like if there were any other accident or injury that occurred during treatment. Marie, do you have any experience or?
No, it's a great question. I'm just thinking, because that is something when you're getting consent that you kind of talk to the patient, like you may hit a nerve, you may get bruising, that's part of it. But at the very bottom, there is that chance that you can get, what is the one in the lung that's the most,
Pneumothorax.
yes, that's the big one. Fortunately for OTs, we're not going to be doing the back, but still, I think that's kind of in the consent.
Yeah,
Dr. Van has his hand raised.
Dr. Van, I'm
Well,
sorry.
like I said, I'll lower it, but I think the most important thing is you have to, how do I want to say this? As we think about this, I think we have to address, it's an institutional situation like Ms. McLaughlin is working in. She has the backup right there. It's very easy. But if I'm, got a rural OT practice and the hospital is 30 minutes away, what am I going to do if I get a real problem? If I get a pneumothorax, or if you all won't get that. But if suppose I hit an artery and I have a significant bleed because there was an aberrant artery, and we all know that not everybody reads the anatomy books and everybody's anatomy is not the same. And so if you get that, what are we going to do with that patient? I think we have to start saying that there has to be if nothing else, a mechanism for management of major complications. And how you do it, I think, is going to be something we have to determine, but I think the board's going to want to see that to make sure there is a way of treating those major complications that you all would not be able to treat.
Okay, I mean, I think, we can definitely put it in here as part of the like consent form or procedural, just to remind people to make sure that they have procedures in place that would possibly be similar and or different to if, another complication that happened during treatment. So maybe we can just put a note in some of that in the area of 6 with Marie, would that technically be part of like a consent form? I've never really seen a sample consent form for dry needling, even though I've had it. I forgot to ask for a copy of mine when I've had it at physical therapy, but I know it's really different for them.
Yeah, I know, some of the places I worked at the PTJ, they have a separate consent form.
Yeah.
For that.
Well, again, I think you're going to have to follow the Louisiana state consent forms for treatment, because I don't think it differentiates who's the treating provider. It just says, treatment. And one, for example, let's just take a situation of an outpatient surgical facility that or you could have a patient that you stick the needle in has a vagal response because they've never seen the needle or weren't comfortable with the needle or whatever. How are you going to manage it? You'd have a transfer agreement. Outpatient surgical facilities have transfer agreements for patients that need to be seen in an emergency room or seen in are hospitalized because of an abnormal response or a complication. And I think, you could have vagal responses, which could really, if you've never seen a few bad ones, you'll understand why I'm concerned about it. But they can look for all the world like somebody's going to die for a short period of time. And I think the key here is, I think you should build it into the rules that say there must be a mechanism for the management in a prompt and effective manner of any major complication that might occur. And then that way it can be unique for Ms. McLaughlin and working at Ochsner, there's no problem. But for Dr. Collado working, for Dr. Mann working in rural Louisiana and the nearest hospital is in the next parish, I got to have something that's available for that too.
I just added as a number 8,
Okay.
basically what Dr. Van just said, when dry needling is performed, the clinic or facility must have a written plan in place for management of major complications in a prompt and effective manner.
That's great. I think that'll solve everything.
Okay. And I guess Marie and Kristen, this question would really be for you. So in number 2B, and I think it was somewhere else when I was reading, because this was something that Randall and I kind of discussed briefly. Do we include upper limb? Do we not make it specific to upper limb? I know Randall was saying that it was used for, I can't remember what he was talking about, maybe pelvic floor or something. I'm not sure.
Yeah.
But like, I don't know, I guess just really y'all's thoughts on this document. I know it's not, you know, perfect and we need to thing, but and then the 24-hour thing is, you know, what are y'all's thoughts on that? Because I've taken that number was a little different in each state.
So we don't typically put out there a required number in terms of the amount of hours of training. We generally leave that up to the licensing boards and the state associations to hash out between the two of them whatever they think is appropriate. You obviously, though, you don't want it to be too high because you'll dissuade people from doing the training. And you don't want it to be too low such that you have people worry about whether someone's competent. So you have to find that sweet spot. Just off the top of my head, again, I think 24 hours is reasonable with the 50 hours of instruction. But, you know, Randall and your other OTs who are here are more familiar with the dry needling. I'm not a trained OT for everyone's knowledge, but I think everyone else who's an OT and everyone who's here can comment better on that than I can. And what was the other question you had about?
Like mentioning it specifically in here, like upper limb, because some states didn't and some did.
Yeah. So pelvic floor is a whole nother conversation being had at AOTA right now.
Right.
So I'm not even going to go there just yet. And I'll also remind everyone, we have our official document on physical agent modalities is being revised right now to include something about dry needling. So maybe there will be something, and I'm not a part of that revision process. That's over in our practice department. Maybe when that comes out, and maybe I'm raising expectations here, there might be something in there about limiting it to a certain part of the body. We don't again, that's not something I've ever seen us do. We generally, again, will leave that up to you all at the state level to determine. So, yeah, we don't have a position on the number of hours or whether it should be limited to a certain part of the body. And I know Tennessee, it's limited to the shoulder girdle and the upper extremities and whatnot. I was not a part of the process of getting that. That was a bill that passed that I think the Tennessee Association supported. And I was not a part of that discussion, so I'm not sure why it was decided to limit it like that. Maybe it was just kind of let's limit it to this part of the body to see how things go with OTs providing it, and then maybe expand it later. Maybe that was it. I don't know. So I don't have a good answer for you, unfortunately.
Okay.
Is there a way to put like 24 hours is the minimum, but if additional hours are included, you know, something that kind of leaves it up to the clinician, because obviously we don't treat the knee, but if they're doing, you know, some upper body stuff and you want to do the neck and the spine a little bit, or like you're saying pelvic health, is there a way to write it where it's up to the clinician to justify those hours?
Yeah, I mean, that's what gets tricky. So I'm just kind of looking at the summary of the other states so y'all have some reference. You don't really have to switch over, but I'll just sort of tell you. And I know, you know, naming the number of hours. Georgia says 90 hours of instruction, but it's just related to physical agent modalities. Not specifically to dry needling. Kentucky says 36 hours of training, just physical agent modalities in general, but they name things like phototherapy, paraffin water. The dry needling from Mississippi, they say you have to have 3 years of clinical experience and 50 hours face-to-face. And then it says advanced dry needling like craniofacial, spine, abdominal will require more training. So, and And then they also say like a written physician's order. And if Dr. Van, you think that that's something that is important, we can always add that. That would be specific to dry needling.
So one thing that we could do similar to Mississippi is to have, we could have a number like 24 hours related to the upper extremity, which we do feel would be the most common use of dry needling in Louisiana by OTs, but also state use of dry needling for other body systems will require more training.
Mhm. Yeah.
And I was going to comment, and I'll lower my hand now. This, when we started talking about this almost 2 years ago, Randall, I think, is the one that made the presentation, and he thought that you should have 24 hours for the upper extremity and then additional courses for lower extremity. And of course, pelvic issues would be entirely different additional training. I think the key here is we have to be able to be sure that, number one, the one thing we have to assure the public is that it's the people who are doing it know what they're doing, and that we can protect them by regulation and licensing. I think that Randall proposed back then, in my recollection, we can ask him if I'll talk to him, but it was 24 hours for the upper extremity. And it was the additional hours were reduced slightly because the technique was the same of how the placement of needle and operation was, but the anatomy was different. And so they had to understand the difference in the anatomy. And I think it's going to be even greater difference in anatomy that they have to deal with when they move into the pelvic area, having been an old OBGYN and understand all of the abnormalities you see in that area. So again, I think it's important that we talk about it as upper limb a minimum of 24 hours. And then as you add, we can reduce it because the technology or the technique of how you manipulate the needles doesn't change. It's just the anatomy you're placing the needle changes, and people have to know about that.
Okay. So that's Ingrid, just for a reference, I kind of switched my screen, but in Mississippi, they have, that's the one that says a minimum of 50 hours, online studies not allowed, and then advanced dry needling, and it names a few, would require more training than the minimum requirements. And then it also states kind of what Marie was saying, it is the responsibility of each occupational therapist to acquire specialty certification through additional training beyond the minimum requirements. And then I mean, Dr. Van or y'all, I feel like it's important for us to put that we have to have a written physician's order for dry needling specifically for that. And that, I mean, what are y'all's thoughts with that?
Well, I think that's fine, because what you can also do is you can build in, if Dr. Collada recommends it and there's a problem, let's say, for example, I was a practicing OBGYN like I used to be a few years back. I could say, okay, I'll send this patient to you for pelvic and anatomic dry needling to address certain problems. And then I'm responsible working with you for the complications. So that if you get a problem, you pick up the phone, you call me, I say, send them to the hospital where I practice. I'll meet the patient in the emergency room. And that's, I think, the way you can build those kind of things in as you do that. If you have to have an order, that's going to then be the person that's going to be working with you to manage complications. And I'm comfortable with that. I think we just have to state it, and that way everybody knows.
Okay. Marie, is that your experience? I mean, I know we're not practicing it, but I know for physical therapy, I had to have a specific prescription that allowed for dry needling. Sorry, I caught you at a bad time.
No, it's fine. I'm getting a snack. I thought, and so what you just said is new to me. I thought that as a PT, they can eval based on, I know in the hospital setting, we do require an order in the hospital, but in private practice, PTs, according to their practice act, they can evaluate and treat as long as the physician signs off on it within 30 days. So that's different.
Well, they have direct access. So technically they don't need the prescription to treat, but they, at least the place that I go, they asked for it or require it. And when I asked about why, because they had direct access, they said for insurance purposes.
So
But
they
then
do have to get an order for dry needling?
I don't know. I don't know if they have to or not. They just said, I think it's more of a like cover themselves for the dry needling, but you know, and I was fine with it because my physician was fine with it, but you know, they did ask for it, whether they need it or they just get it as part of like procedures to cover themselves for liability. I mean, I can dig into that, but that's really just the facility where I go, and that's the only place I've ever had it done. I don't know if anyone else has any experience having it done and if they've needed a, but I feel like for OT, like Dr. Van said, we should say that, you know, we need a physician's prescription specifically for dry needling.
Current outpatient, occupational and physical therapy practice, usually a physician just writes a generic thing like OT 3 days a week
Right.
for blah, blah, blah. Then the
Evaluate
OT evaluates the patient, writes out all the modalities and interventions they're gonna do, sends it back to the MD signs off on it, and they have up to 30 days to sign off on that. So what we would be saying that we want different here is that we want it on the front end, that or that we don't want the dry needling to happen until we get that paper back from the physician signed saying that dry needling is okay. I think that's what we're saying.
I mean, I'm bringing it up. I'm not saying that like, and just.
I don't think we have to have the physician write a prescription specifically for dry needling on the front end. The physician may not even know that that might be a good thing to use. If the OT evaluates the patient and feels like this would be a good modality, then I feel like that should be, the communication should go back to the physician. We would like to use dry needling. Can we get a prescription for dry needling?
I mean,
Yeah.
I guess it goes back to Dr. Van, like what are your thoughts with that? Would it be covered under our general prescription? I mean, so the thing really here, and just to kind of give, you know, Kristen probably knows this, but Marie, just so you know, like once we amend these rules and regs, they go to the board, who then like will sift through them and make comments. And what we're trying to do is like upfront with Dr. Van's assistance, appease them or do what we think that they would want, so that when we present it to them, that they will then be okay with it. So then it goes through like public comment and then the whole process. Dr. Van, your thoughts on whether or not we need to put in there that we need a specific prescription for dry needling, or do you think it would be okay if it's just covered under our general script for evaluation and treatment?
Well, let's look at a unique exception that we have right now for without prescription and treatment in the, let's say it's a school environment. Okay. Right now, you don't have to have a prescription to do what you do. So if that person decides that that OT decides somebody needs dry needling in a school, technically the way the rules are written right now, that would be an exception. They could do the dry needling without having anybody available to manage the complication or handle having given an order to do it, because we've given that exception. But do you want to give that exception for dry needling?
Yeah,
you know,
You still have to have the consent though from an adult.
yeah, but consent from an adult, and let me just bring this to you a little bit differently. The consent from the adult is evolving. There's already stuff in the Children's Code in Louisiana that you are a major for the treatment of pregnancy and its complications, sexually transmitted diseases, and contraception. So let's say some OT decides, oh, this person's having round ligament pain early in pregnancy, and they're a student in the school, and they decide to do some dry needling for round ligament pain, and they end up doing some damage. There's no doctor order. There's nobody agreed to handle the complication or anything like that. I'm not saying it's going to happen. And I guess what I'm trying to tell you is we see all kind of crazy complications here at the board that end up being complaints. And what I want to do is give you all a sense that the board's going to want to have a set of guide rails, and that's what the rules are, that are going to protect the public. And I'm not saying they're going to go one way or the other, but I think how about I put it this way? How would you want it done for your child? Okay. Would you want a doctor's order? Would you just want the school therapist to do it? I mean, again, I think that's the key we have to think about. And I'm not trying to put any cold water on what you're trying to do. I'm just trying to build in a set of guide rails that's going to protect the public and that the board will be comfortable with.
Thank you. Kristen?
And so I mean, I don't know Dr. Van, but I respect those comments tremendously. Absolutely, patient safety is very important. Just something to think about when it comes to the requiring orders or not. Some insurances might require them anyway. And if, generally speaking, requiring an order could be a barrier to care for someone. Like if they're in I didn't sleep well last night, so I'm having trouble coming up with a scenario that, well, here's an example. Let's say they're at the physical therapist and the physical therapist says, I recommend dry needling, and the PTs don't need an order from a physician. Maybe they do in Louisiana. Let's just suppose they don't. They're going to have the PT do it right then and there, as opposed to if they need an order from a physician to go to an OT, then, they'll see a PT for something they could have gone to for an OT. Now, you can certainly, I guess, go to both for various, interventions, but, I mean, we hear stories there's lots of discussions at the federal level. I'm not an expert on insurance and how all that works. We have folks in my office who are more knowledgeable than I am. But prior authorizations and orders and whatnot are something that's being looked at the federal level. And there's been lots of discussions because they've gotten ridiculous over time. And they might have had originally starting out there might have been a good reason for them. But now I think there's some concern from especially patient advocacy groups that they're a barrier to care for some people, especially folks who can't have trouble getting time off to go see a doctor, or they have limited transportation available to them, or they just don't get around very well. Maybe they have trouble walking, or they're wheelchair bound or whatnot. But that's just something to think about. Again, we don't have a position on whether an order should be required for dry needling or not. That's something you all will I think we defer to you all on, but I just wanted to put that out there for a thought.
Thank you.
And maybe let me give you a bit of historical perspective so you'll know how we got to where we are. At one time, the PTs were under the Board of Medical Examiners. And when PTs wanted direct access, the board did not believe it was the right thing to do medically. And so they went to the legislature and got their own board. Subsequently, if you paid any attention to what happened to the PTs in Louisiana, about 3 years ago now, they were called on the carpet because they were not adequately disciplining their people. There were accusations of sexual misconduct in doing female pelvic physical therapy. People were not being disciplined. They were called before the Senate. It was a big mess. They had to change their board. They had to change their lawyers. And so, again, I'm not saying, I just want to give you a historical perspective. I think the board is going to say and come down and say, we want you to do it. We want these guide rails. We want these protections built in. And I understand and I think the board would be very understanding as well. If you said, hey, we think that's the wrong thing to do, we're going to go to the legislature and get out from under the Board of Medical Examiners. Again, I think that's certainly a possibility. I don't think it's going to happen anytime soon, but I do think the board's going to want to give good guardrails to make sure we keep the practice safe. And after that, I don't think the board's going to be too concerned about how insurance handles it, because that's not our business. It's how we expect the practitioner to have a set of guide rails to protect the public. And that's really all the board's going to ask for.
Okay.
Does anybody have a problem with the way I wrote it in here? I just added as number 5, dry needling may only be performed with a physician's prescription. I mean, we've not direct access, so I don't think this is onerous for OTs.
Yeah, I mean, I think that's fine.
I don't think it, I mean, I would personally feel better about having a prescriptions asking for it. But that's just me. And I don't, I'm not an orthotherapist or whatever, but
So I guess my question with that, the way that it's written is, I could say, oh, well, I have a physician's prescription for OT. Like, are you saying with it written like that, it has to be specific to dry needling? Because I might read that and say like, oh, well, I have a script to treat them, so that's fine. But if we're saying like, we want, like Mississippi says, each licensed occupational therapist performing dry needling must have a written physician's order for dry needling. Like,
Okay,
which you
just
want.
add that for dry needling.
Yeah. Just to be clear, so that it's not taken advantage of.
Yeah.
Marie, what's your opinion?
Yeah, you may have to clarify. So if we get an order that says OT eval and treat, we write our plan of care. And then at the bottom, we say, whatever, splinting, ionto, dry needling, and they sign that. You're
Yeah.
saying that's not okay, or it
Oh,
is?
that's good to go.
It's that's fine.
Okay. Then I think that's fine. Yeah.
But like if we're in another setting and, we're treating and then we say like, oh, dry needling, or now I take my CUs and I become a practitioner that's able to perform it, and then I want to do it on a patient, then I would have to get a prescription to do the dry needling. You see
In the
the-
way that you just said, Marie, just like
Right.
you said.
Yeah. Okay. And then I think the other thing that we need to add is, maybe again from Mississippi, that the advanced dry needling and name in like craniofacial, spine, abdomen, whatever we want to put there, would require more advanced training. And that is responsibility of the OT to acquire specialty certification through additional training beyond the minimum requirements. Like, are y'all okay with that if we add that to the part so that we have the 24 hours minimum for the upper extremity, but if they want to do something else, they would have to do more.
I like the way that sounds.
Okay.
I'm kind of confused on where that would go.
I think it would be, I was looking, I think it would be C under 2 for the mandatory training. So like A is just the areas, B would be the 24-hour for upper extremities, C would be the place for the advanced. And I can't cut and paste it because I'm not on it, but I can get it to you, or I can read it to you if you want.
I'm just going to right now, I'm just going to put in state of Mississippi advanced practice. And then you can
dry
send it to me.
needling. Yeah. And then what do y'all starts? Do y'all want us to put therapeutic dry needling, functional dry needling? Do we just keep it to dry needling? Amy?
I just wanted to let you know, I was texting people as y'all talking. PTs in Louisiana do not need a specific order to do dry needling at all. So I just
Yeah.
wanted to let y'all know that definitely don't need anything. They can just do it if they think it's appropriate. They don't need anything. I do like including other body parts and having additional services, but not limiting to just only being able to do the arm, I think is really good. But I do like having a prescription. And I'd like that idea, like Dr. Ban said, you have if there's an issue, you have a doctor to call on to say, this is where.
Yeah.
On to him.
And then, okay, yeah. And if y'all want, I think I sent it to y'all. I'm not sure because I think I do a lot of things. I have the PT's dry needling. I may have gotten it from you, Marie. I don't know where I got it. You, Randall, somebody sent me like the PT thing. It does not have anything about a script. It's very, very general. It's literally A through F. So it just says that they have, their training is no fewer than 25 hours in-person hand-on instruction. That's like one of their things. And basically the board has to approve the courses. They have to educate the parent of potential risk and benefits, document it in the record, and then consistent with the Center for Disease Control and Prevention. And then it says that it says that a student may practice dry needling under the continuous supervision of a PT who has completed it. They don't say anything about a PTA, but they do say that a student can do it. And maybe that's because that they're putting it in their core curriculum now. I'm not sure, but if y'all want a copy of that, let me know. But okay. And so the only other thing that y'all felt like we needed to put in here, and this, I guess, you may have put it, you'd have to scroll up, Ingrid, would be under the consent, number 6. I think you added a number 8, you said, or
That part?
no, go
I didn't add
down.
anything under consent. I added 8, 9, when dry needling is performed. Yeah, let me turn this green because I changed that. But I don't think we thought that that would go in the consent form.
No. Yeah, well, you have it under number 9. I just
Yeah.
wanted to make sure you put it in. I think you had scrolled before I verified that. I just kind of had a little list of everything that we needed to change in there.
Yeah, so we really have not agreed on whether we're calling it TDN versus DN yet.
Yeah, nobody really said anything. I don't know what to do about that, but
I think just dry needling,
okay,
but that's me.
okay. I mean, I'm fine with it. I wanted to bring it.
Yeah, I think just dry needling is fine.
Okay. And then Ingrid, you can delete the last statement.
Okay.
Because that was really,
This one?
okay, so just to recap, we have the minimum of, we have the definition. Everybody's okay with that definition.
Darby, before we recap, one other area we didn't really fully discuss is who approves the continuing education courses. That was still a question. That's why I've got that highlighted still here.
Oh yeah, thank you.
I mean, is there a reason why we don't have this as LOTA, comma, AOTA, comma, NBCOT, our overall approvers?
No, it was just me kind of going in and putting things that, you know, like I said, some of them do it specifically to the board. And then some of them, it's not in their rules and regs, but it's separate, but you still have to like show the board that you're competent in it to get like quote unquote permission. And then some have it in their rules and regs, and then some don't mention it. So like whether they're doing it or not, like, you know, I guess they're thinking to ask forgiveness rather than permission. So it's, and then some specifically say like, no, you can't. So I just put it in there and then was changing like board to what we would want, but then felt like, what is the role of our board with the compact with doing this? Like we talked about earlier with Kristen of like, if our regulations are different than their regulations, how are we going to handle that? Is that going to be something we want? You know, obviously that's a board thing and not an LOTA thing. So I don't really know how to handle that part of it because with the compact coming, I don't know.
Well, just backing up just to the actual courses themselves and who approves the courses. It feels to me like we would keep our normal practice of that. The courses themselves would need to be approved by AOTA, LOTA, or NBCOT.
Mm-hmm.
That would be my point of view.
Yeah, so that would be number 3 where you have the LOTA.
Right.
Well, and
Yeah.
isn't it too, I think you're right, where it says the LOTA, that would be the LOTA, AOTA, NBCOT.
Yeah,
But then isn't it a separate issue if I'm coming from another state? I've already had the continuing ed approved in the other state, but I still have some onus to show the board that what I did was
correct.
legit, was according to our state. So it's two separate,
Two separate things.
right? That's the way I'm understanding.
Kristen, you have your hand raised?
Yeah, I just want to make sure we're not writing the reg so that people think if I want to do dry needling in Louisiana, they submit their hours to us. Like
No,
they would submit that to you, right? And if
correct.
they were approved by,
Hopefully.
yeah, I mean, we don't want that responsibility. That's your authority. We don't have that
Right.
authority legally either. So
Right.
if the course was sponsored by us or LOTA or NBCOT, then you would approve it, I would imagine. Most states do. And
Yeah.
then, but they show the proof of their training to you all. So I just want to make sure that distinction is clear when you write the regulations.
So maybe in that, Ingrid, instead of like where we say another state or country must provide the same documentation to the LSBME board. Or licensing board, I don't.
If I may give a bit of, again, a perspective, Darby, what we see in the medical compact, the physicians compact, is that the vast majority of these people are doing telemedicine / telehealth. They're not really doing a lot of hands-on. And I don't particularly see a lot of people that are going to be joining the compact, except if they're perhaps in Mississippi and want to have an office just across the state line, Texas, Arkansas, that kind of thing. But if somebody's in Oklahoma, the likelihood of them doing anything other than telehealth is very slim and none. And so I don't think it's going to be as onerous as we think, because, you know, there are a lot of physical modalities that have to have hands-on touching for you all to do your work. And I don't think that the technology is there yet. It may come, but I don't think it's there yet to be able to do some of the things. Just like, for example, we have had to discipline doctors because they took their canned documentation and on a visit for upper respiratory infection, documented things like abdominal exam, rectal exam, pelvic exam, and that kind of stuff, which we knew they couldn't do because the technology didn't allow it. So again, the technology is going to dictate what they can do. And right now, unless there is this unique desire to drive into Louisiana to treat patients, most of this is going to be the kind of stuff that nobody's going to do dry needling over TV or video or Zoom or anything like that. So I'm less concerned about that than I am about the people in the state that are going to be doing it.
Yeah, I agree. I just feel like we need something in there for the people who either come here and don't switch their license completely and just use the compact, or in the areas that are surrounding the state.
Yeah.
For it.
So would like travel therapists be an example?
Yes, travel therapists would be an example. They would probably want to do it. Just like we have, for example, we have physicians that live in Florida that come once a month and do a weekend from Friday to Monday in an emergency room. And then they fly back to Florida and do what they do the rest of the month. So again, I think those kind of people will be the ones that this is affecting. But by and large, those compact licensing people are doing telehealth, and they really aren't doing much hands-on work.
I have a question about now. Right now, when you do a license for to practice in the state as an OT, we have that process that we go through. Now, if they had to provide documentation for being certified for dry needling, is there some place that is going to be obvious that they submit it to, or where would they submit it? I guess that.
Well, again, what we would be, it really depends upon what evolves at the compact in terms of the data points that are required for the evolution of the compact. And as an aside, I've been appointed to work on them, and I've been working with Miss Amanda to get this stuff together for our board and you all. But again, I think this is an evolving situation right now. It's still how do I say, it's in process right now. It's not really decided. And so what's going to happen is there will be, I suspect, some post licensing requirements, or I should say post privilege requirements, that we will have to get people to supply. We cannot and probably will not be able to, if it patterns after the medical compact, deny the license, okay, or I should say the privilege, but we would have to get some additional stuff, and we do that now for docs as well. So we're set up, geared up, and can do that if we need to.
I separated out the course approval from the whole idea of somebody from another state.
Mhm.
So I just created a new number 3 in green. AOTA, LOTA, or NBCOT must approve the occupational therapist dry needling coursework before the therapist can practice dry needling in this state. As one thing, and then separately now, any occupational therapist who obtained the requisite hours of instructions as described in another state or country must provide the same documentation to the LSBME.
So,
That makes it
the
sound
green
like,
number 3,
yeah,
sort of contradicts what we're telling them to do for their regular
yeah.
CEs and coursework. So I think that would be confusing.
I
And
thought that is exactly what we're saying they have to do with their other coursework. Their other
I think
coursework also
it's-
has to be approved by those.
No, I think under 2A, where it has instruction of the general, in the 4 areas which are generally satisfied during the normal coursework, or continuing education from LOTA, AOTA, or NBCOT approved continuing. That makes it sound like I get my I take a course, and then I have to get AOTA, LOTA, or NBC to approve it for them to do the dry needling. But really what we're saying is the course that they take has to be approved by LOTA, AOTA, or NBCOT, just like any other coursework.
So you feel like the way I have it written doesn't say that?
No, I think you take out 3, and correct me if I'm wrong, Carolyn, I think you were saying the same thing, but in 2A, we need to put NBCOT as the approved course provider.
Each, you mean up
Go up,
here?
go up higher.
Up higher,
Keep going, keep going.
2A.
Right there.
Instruction in, oh, I see. From an
That's where it needs to say
or
LOTA, AOTA, or NBCOT. So in other words, that course has to meet all those requirements. It has to be like 24 hours. It has to be in person, blah, blah, blah. And then it also has to be AOTA, NBCOT, or LOTA approved. I think the way that you wrote 3, it makes it sound like I take the course, then they have to approve it in order to do dry needling. And it's sort of redundant if we have it up there.
okay. All right, so I'll take this back out.
And then
And
I
then
also
I
think,
would still have to say then that it needs to come out from this number 3 too, because this, the
Can I
LOTA,
make-
that's confusing.
Can I make a suggestion?
sure,
At the beginning of this section of the rules, you can put in definitions. And you can say definition of an approved course is, and that settles that for the rest of the
Yeah,
time.
that's a good idea.
You can put in definition of whether you want to do it as TDN or DN or both. You can say dry needling means this. So you have those definitions that are there that are going to define what's used in the rest of the section. Is one way that rules are accomplished throughout our rule manuals on all of our disciplines. So you may want to consider that as a function at that point.
yeah, we'll have that in the rules, the dry
At the
needling.
have the beginning of the section, you make these definitions, and then whenever you refer to it, it's based upon the definition that's in the section.
Okay, thank you. And then Ingrid, I think okay, I know we need to deal with 3. So any occupational therapist must provide the same documentation to LSME.
I'm just saying this part here that I've just highlighted feels like that should not be in this section. We
Yeah.
already referred to it earlier.
Right, you can take that out. And then I also feel like that last part of the first statement is redundant. Any occupational therapist who obtained the requisite 24-hour of instruction as described in paragraph 2B in another state or country must provide the same documentation to the LSBME, period. And then that's it. And then I think you can take out number 6 that says an occupational therapist practice in dry needling must supply written documentation upon request by the board that substantiates, unless we want to leave that like, but I mean, I think that's a given that at any time we can ask for training.
I have no idea if that's a given or it doesn't feel like a given to me, but it might
Okay,
start.
all right, well then we can leave it. Yeah,
I would suggest for what it's worth leaving it because it kind of signals to the provider that they need to hold on to proof that they
Okay.
did their training.
okay. And then
And
in
then
number
other
8,
boards have similar language in there about just CE generally, that, you know, the board reserves the right at any time to make the
Right.
provider supply proof that they did their CE, that kind of stuff.
and then in number 8, take out the word therapeutic. Yeah, you did. Okay, sorry. Any other questions or comments?
I feel like 3 is still unclear to me. Any occupational therapist who obtained, I guess, instruction in dry needling in another state or country, or instruction in dry needling and I don't know, permission to practice it in another state or country must provide proof of meeting the state of Louisiana's minimum requirements to LSBME.
Okay, so let's see.
Well, but my only concern, I see where you're getting, what you're getting at with
Yeah.
that. My thought is like, let's take Wyoming because they require training for dry needling and have regulations. If the board doesn't issue some kind of a certificate or proof that you met the training, what is there then for them to supply to you all other than proof that they took all these 24 hours of training?
Well, that would be it. That would be the proof.
Oh, that's what you want. Okay.
Yeah, that would be.
But so say they move here from Mississippi, Tennessee, Wyoming, whatever, and they did their requirements and they move here and want to do dry needling. So if their course wasn't 24 hours, they would have to meet our requirements. So what you're saying is if they obtained it in another state, I think the way that we change it, it sounds like if they took the course in another state.
Right, that's what I'm trying to differentiate. Because
Brenda,
Louisiana therapists might take it in another state.
right, Brenda, is that what you're?
Yeah, and I was thinking like some way to have words like if I did the training to meet another state's requirements. I don't know if that hits it or not, but yeah, but to get away from like I took a course in Florida, so it doesn't count.
So the way it was originally written, because I know we've chopped it up, it says the occupational therapist who obtained the 24 hours of instruction as described in 2B in another state or country must provide the same documentation to the board as described in 2B that is required of a course provider. the LOTA or its continuing education consultant must approve the OT's dry needling coursework before they can do it. So in other words, like if you were living in Mississippi and you took your course and you've been practicing and you moved to Louisiana, then LOTA or LSBME would have to then approve it to give you permission.
And I'm thinking out loud at this point, would it, is what we're really saying is if you got your training in dry needling before you were licensed to
Right.
practice in Louisiana.
But really, I think the purpose of that was more for the compact.
Right.
So not, but I think we have to differentiate it between like me, who goes and takes a course in Florida because that's where it's offered in the time that I can go.
Right.
Versus say, you know, Karen, who is moving here from Mississippi and has been doing dry needling in Mississippi for 2 years and moves here. Or has the compact and is practicing here. So Glenn put up a thing that says an occupational therapist who is currently certified in dry needling in another state must provide ...
I think that's kind of, see what you think about what I wrote here. Any occupational therapist who obtains the requisite hours of instruction to meet another state's requirements for dry needling must provide the documentation to the LSBME that demonstrates compliance with Louisiana's minimum instructional requirements as outlined in paragraph, whatever.
I like it.
I like that.
I like it too, but is to meet the right thing to say?
I don't know.
What did you
Well, let me
say?
say
Is
this.
what-
Like,
I don't, my concern is, let's make our intentions clear, because ultimately Pat's going to put this in APA language that is
right,
the legalese of making this work. Okay, so again, I think what your intention is, you want them to present an additional certificate, and that's fine. We'll make it work, and I will take that thought to the people that are putting together the compact as a post-licensing requirement. Because most compacts allow the states to have post-licensing requirements. You just can't keep them from getting the license. You just have to deal with getting their requirements afterwards.
yeah, I just think it's clear the way that Glenn said that an occupational therapist who's currently certified in dry needling in another state, and then, because
But not all of them are going to be providing certification.
Again, make your intentions clear, and the legalese will be taken care of by the legalese people, not us.
Okay.
Not every state is going to provide certification. So we're just saying anyone who's done the requisite hours of instruction for another state's requirements has to show that they are complying with our minimum requirements.
okay. All right,
So I'm not sure that so I think what and I agree with Dr. Van again, be as abundantly clear as you can about what your intentions are, and the legal people will take care of it later. But, and I'm not an attorney either, but I try to think like one and write like one. Is your intention here to not make people do 24 hours in Louisiana if they did hours in another state? Is that what you're getting at?
That's what I would be wanting to get at.
Okay, and I think that makes sense, and that's generous of you. I'm not sure that the way you have it written there says that. That seems to say to me that you did it in Mississippi and you're coming here and we want to see proof that you did it here. It's not entirely clear that what you did in Mississippi, you're going to look at and be like, oh, okay, yeah, that does meet our requirements, so you're good.
The dangling here is the issue. And I think Louisiana wants to see that same credential to be able to grant you that privilege in Louisiana, because it's not going to be automatic, because it's not part of clinical competence, core competency. It's additional. So we'd have to be able to verify that that current clinical competency exists.
Right. I think I would write it and just say, if they did however many hours in another state, they need to show proof that they completed those hours in that state and show it to you all. And then you all decide if it meets your requirements or not. And if they need to do a little bit more, or if they need to take a subject here that wasn't required there, then you can have them do that. But they don't need to do a full 24 hours here if they did 24 hours in another state.
That would be our way of interpreting it.
Yeah.
But again, that's why I think it's abundantly important to say, just like you said, tell us what you want.
Yeah.
And the legal people will write the legal language to make sure it is what you want.
Yeah, yeah. Or
And
come
then
back to you and
remember-
say,
yeah.
hey, you don't have the authority to do that.
Right.
So I think it needs to say something about like an occupational therapist who is practicing dry needling in another state. Or, I mean, I know there's like no certification, but because basically the way this is written, it's saying like, oh, I can go and take a course in Florida and it's only 23 hours. And then I can come to y'all and say, hey, does this meet the requirements?
No, because our requirements would be 25.
Right, I know, but that's what this sounds like, that you meet the requisite because they,
No, you have to meet Louisiana's requirements.
It says you have to meet our minimum requirements.
Again, if that's what you wanted to say, just say it and Pat will get it right. But again, I think I think you all have great thoughts and we want your concepts. But in terms of wordsmithing, let's not debate the wordsmithing. Let's let the wordsmith experts do that.
okay. So in good at the end, it would be as outlined in paragraphs 2A and 2B. Because that's what our requirements are.
Okay, did you want to kind of go over the whole thing again?
Um,
Or not?
Y'all think we
Okay,
need
okay,
to. I mean, I don't think we need to change. I guess in number A, you can take out the word Tennessee. And then I don't do under the mandatory training under A, do we want to keep like course of study in an occupational therapy school, like leave the school in there? Because it's not really normal course of study in school.
Well, it can be, I mean, we don't know that it isn't.
These, actually, yeah, it is a little confusing here because these 4 items are covered in school.
Right.
And so therefore, this whole part about the LOTA, AOTA, and NBCOT approved provider feels like it needs to come under here under B.
Well, and here's another thing to think about. I don't know that we offer a course on trigger points right now. So if you're going to require someone to take a course that on trigger points that's approved by us, there isn't such a thing. It doesn't exist right now.
Well, that's
It
usually
might down the road.
2A and 2B are what we're saying has to be part of the dry needling course.
Oh, okay. Oh, sorry. Gotcha. Gotcha.
So if that's not clear, then we probably need to change that, like, right, Marie?
No, I think it is. I
Yeah.
think it is.
Yeah.
I misread it. Sorry. Yeah, it
Yeah.
says must complete educational requirements in each of the following areas. Okay.
Yeah, so like the course that they take has to meet these requirements.
Yeah, I got it. No, I think it's clear.
Okay.
Like I said, I just misread it.
Well, and you're right, not every, I don't even know myself exactly how much education we're giving on trigger points in the school. So in order to learn trigger points, they may need to take a course.
But it would be part of the dry needling course is what I'm saying. So that's, I think the school thing was like, I assumed that the school thing was because maybe some states are starting to put it into school, like PTs are. Maybe I'm
Yeah.
wrong. So if that's confusing, then, you know, but basically we're saying like, before performing, you know,
So that would wind up being, I think we take that out, which I do actually agree with. It would
okay,
say instruction in each of the 4 areas listed herein from an LOTA, AOTA, or NBCOT approved continuing education provider.
yeah. And then, so that would be that. And then the 24-hour dry needling must include specific instructions related to the upper limb and the 6 areas.
So, Darby, is that saying that I have to take courses in each of those 4 areas? And then my minimum 24 hours?
I don't know, like now I'm like super confused as we like go through this. I'm looking at, let me see something.
And would it be better to start like under mandatory training, saying there, like the mandatory training as is required with other continuing education must be approved by LOTA, AOTA, or NBCOT, approved or sponsored providers?
Okay, so maybe I had it wrong. So I went back to Tennessee, which is where I got it. And it says, in order to perform dry needling to the upper limb, the occupational therapist must obtain all of the educational instruction described in 2A and 2B. All such educational instruction must be obtained in person and may not be obtained online or through video. Mandatory training before performing dry needling, they must complete educational requirements of each of the areas. This says 50 hours of instruction to include those 4 areas. And then 24 hours of dry needling. So it, I mean, it, I don't know if it's, I don't know. I mean, if I assume that that was part of the dry needling training, but I see now that y'all bring it up that maybe it's not, and they're saying like you have to have instruction in those areas. But I'm pretty sure that when I talked to Randall, it was like that was part of the dry needling. So it could just say, and I think the 24-hour hands-on is really to the B part, right? That's the in-person part that you have to get like, and then the other part is just components of the training. So they need to address trigger points, universal precautions, pain mechanisms in the dry needling training. But the part that's specific to the upper limb has to be at least 24 hours. So in other words, I think what they're saying is like the 24 hours can't include all of that, but the 24 hours has to be specific to the technique of dry needling.
So it is more than 24 hours of training, like Brenda said.
Right, so that 24 hours would be specific to dry needling, and the other part, so like Randall said, his course was like 27 hours. Some of them are 50, some are more.
So
Well, I took a course and I mean, what they did was they started off just talking about, and that we had a lot of stuff to prepare for before we ever got there. So a lot of reading and all that stuff. But once we were there, they would go through the musculoskeletal system of the area that we were needling at that point. And they did like a little thing about the pain and chronic pain, all that was covered in the course. But it was I think mine was like, it may have been 30 hours or something like that. But so are we saying it has to have hands-on, like you have to be needling for 24 hours or?
No,
It just says the 24 hours of dry needling must have specific instruction in those 6 areas.
Do you see why I'm thinking
Yeah.
This says 24 hours of dry needling.
Dry needling instruction.
Yeah.
Well, I mean, again, there are didactic portions of a course. There are physical modality portions of a course. I think we're just saying the whole course has to combine all of those things and be no less than 24 hours.
Yeah,
Yeah.
that's what I think, but just reading it.
That's how we would interpret it. I can tell you that.
Right.
Yeah.
I mean, the other thing is you can just combine A and B and put a minimum of 24 hours. And then, you know, it just has to include the systems, the pain, the trigger points, universal caution, and
Well, what you don't want it to do is to be all online. You want it to
Correct.
have a mix.
right. Which we don't say, I mean, I guess we might need to put like in person because we don't, where is that part? Oh, allowing self-study and partial online. The majority of the educational instruction must be obtained in person. So that's a
So
number.
you've got the definition there. You can just put that in there.
Yeah, so that's there in number 1.
And you still have no public comment, Madam Chairman.
Okay, thank you. So Carolyn, you think it still needs to change? Is it still confusing?
I think it is a little still.
I think that covered it. I'm just
Okay.
trying to read it from a perspective of somebody that's not in this conversation.
No, and that's exactly what we need. And also like maybe take your continuing ed brochure and see if you would look at it and then look at this and say like, oh, okay, this would be, if it's not LOTA, AOTA, or NBC, you know, like.
Yeah.
Assuming you took something that was AOTA or NBC approved.
So are you saying that it does need to be 24 hours of in person, or can some of it be online?
It should be an adequate mix to assure proper training. Is, you know, again, we're going to let the course provider that gets the approval going to be the one that's going to decide how much of it has to be online, how much it has to be in person. And we're going to trust the AOTA, the LOTA, or whoever that credits that course, that's going to be something that they are making a good requirement to assure that the person is well trained in the modality.
I added in person here, but I can take it out.
Yeah, I think you're gonna have to take out that in person, because in 1, it talks about the majority has to be in person in case it's not the 20, right, Caroline? Isn't that what you're saying? Like in Kelly, the 24 hours?
Yeah.
Part.
Well, again, you know, adult learners learn better with self work going to a hands-on course. And I think the key here is that it should combine both. And again, I'm going to trust AOTA, LOTA, and NBCOT to determine what is the proper mix of hands-on and didactic. And I think that's what we should do. Otherwise, we're going to be setting the rules, and it may not be what the NBCOT or the AOT says, AOTA. And we made a decision a long time ago to trust their judgment in determining the quality of courses.
Right. Okay, so is this something that we want to sit on and maybe vote on it next meeting, or or y'all feel comfortable that we can vote on this now and then we'll see kind of?
I'm good with voting on it.
Okay.
I just added the exact language that you sent me about Mississippi. Here under C, advanced dry needling, i.e. craniofacial, spine, abdominal, etc., will require more advanced training than the minimum requirements. It is the responsibility of each OT to acquire specialty certification through additional training beyond the minimum requirements.
Yeah, okay with that? And that's so if they do something other than the upper limb. So should it say will require more advanced training than the minimum requirements for upper limb?
I like that.
Upper limb instruction or train, I don't know if there needs to be another word under that. Brenda usually catches that.
Just not sure what that other word should be. It is missing something
Instruction
there.
or, yeah, the instruction or training.
Well, we already said will
What
require
do we
more.
call it?
Yeah, no,
What
not
do we
training.
call it in the beginning?
Yeah. Or upper limb instructional course. Meaning the whole course. I don't know.
Or just more than the requirements outlined above? Like, what do we call, what do we in the, and I can't see further up, like, what do we, when we talk about, it's just for upper limb, what do we call it?
Mandatory training, it says, then there's a like upper, the instructional course.
Yeah.
Educational instruction.
I actually like what Brenda just said. Advanced dry needling will require more advanced training than the minimum requirements outlined above.
Yeah. Okay. Thank you. Okay. Any other questions or comments before we get a motion?
If we're gonna vote on this right now, do you still want me to check on how the training will work with the compact and everything? 'Cause
Yeah,
I
I mean,
don't
we
think the
still have,
compact's made that decision yet.
yeah,
Well, that's true. I mean, the more I think about it, there's a distinction between training for your, that's continuing education to maintain your license and the training we're talking about here to do an intervention.
Right. I mean, I'm going to be at those committees and I'm going to make sure we convey that message and any other message that this advisory committee wants to convey to the compact. I want to be a conduit and not, act arbitrarily without y'all's.
Are you a
understanding.
delegate to the OT compact or the physicians?
I'm actually now both.
Oh, okay.
yeah, that's on our agenda for later, but yeah, I mean, I feel comfortable like for us voting on it because we still have a whole like revision process of the rules and as a whole.
Yeah. And I don't want to hold you up certainly, but I
Yeah.
just wanted to ask, is that the piece that you want me to get clarification on before you vote or not?
Yeah, I'd say still get clarification and we'll, just so we can move on.
Okay.
Brenda?
Just making sure we have the right linguistics for number 5, about the physician's prescription. And want to make sure that, 10 years from now, when somebody did this based off of the physician signing off on the intervention plan, someone's not coming back and saying, but you didn't have that little square piece of paper, that's a physician's prescription. And I don't know enough about the linguistics, but that just keeps like.
Well, if you want to just say on the order of a physician. And that way you can, a prescription means one thing, but again, if you talk about the little piece of paper, just say with an order from a physician.
That feels better, just as, again, trying to read it as someone who doesn't know anything about any of this, and or maybe, an attorney coming back and trying to read it or something.
Well, rest assured, we have a really great attorney in Miss Pat who will make sure this thing gets well done. Trust me. She's very seasoned and very experienced. And unfortunately, a little bit overworked, but we're trying to make it work for her.
Dr. Van, can PAs prescribe, and are we limiting ourselves with the word physician?
Well, again, I think that if you want PAs to prescribe, we will have to make sure that we strengthen PA supervision, because PAs can only, for example, do what is in the clinical practice guidelines. So it's kind of a stepwise evolution, and we're in the business of revising that right now, so you'll know. But again, or you can say on the order from a physician or otherwise authorized prescriber or provider. How's that?
Thank you.
I still feel like this has to say that it's specific to dry needling. So the way that you had it, like, it made it very clear that, like, even though I have an order for treatment, that then I need a specific order for dry needling.
And I think that's because traditional modalities that you use do not have the kind of potential complications and invasiveness that this has, which is why you're singling it out as a protection to the public.
I just added it, Darby.
Yeah, but maybe if it says like dry needling may only be performed with an order specific for dry needling from a physician.
Well, I think let Pat handle that.
Wordsmithing, Darby.
Yeah.
Let Miss Pat handle that.
Yeah. Yeah. Okay. Okay. And then the rest is like the informed consent, and then in compliance, which, okay. Yep. All right. And then the only other thing that some states did, which we didn't really answer, is are we going to set a standard for how many years experience somebody has to do dry needling?
Define what you mean, how many years experience to do dry needling.
So,
Like, can a brand new graduate do it?
yeah, they're in some states. I can find it if you give me a second, if you want it, that says like you had to have 3 years experience, a minimum of 3 years clinical experience as a licensed occupational therapist.
I think that was Mississippi
It is.
mentioned earlier that said that, yeah.
Yeah.
Well, let me ask you this. If a new graduate gets out tomorrow and goes and takes this course and is able to do upper extremity dry needling because of the training, additional training that they got beyond school, has passed their certification exam, do you think that they should be able to do it?
I do.
Well, then you've answered your question. It's
Okay.
not years of experience. It is the training that we have set as the requirement, not how long they've been in OT.
Okay. I just
Great.
wanted to ask because that was one of the things that other states did that we didn't specify. So
Look, like I said, we're going to put down what you want, and the board's going to say yes, no, or maybe so. We're going to have to fix it.
okay. All right. So would someone like to make a motion to approve this section, and then we'll figure out where it goes and how it fits in?
Yes.
Make a motion.
Who is that?
I'm sorry. who was
Carolyn.
that? Carolyn.
Okay, I'll second it, Darby.
Okay.
All in favor, please say aye.
Aye.
Anyone opposed? Anyone abstain? Do we have any public comment?
No, ma'am, we do not have any public comments.
Okay.
Just a good discussion, and thanks for inviting me to participate.
Thank you.
Thank
Chris.
you for your input.
I told them, and I know you weren't on yet, I gave you many accolades for all your support for many, many years from of doing OTAC and everything else I've done, but such a wealth of knowledge and always so helpful and friendly. So thank you. Thank you.
That's very kind. Thank you.
Yes, I really appreciate it. And I always love our visits at every conference.
Send a note to Chuck Wilmore.
I will right now. I'll put a note. Yep. Thank you. And then also to Marie, thank you for being here. I know it took a lot of time and for working with us on this, providing feedback with Randall.
No,
Um,
I've enjoyed my
I know
time.
you
Thank
had
you
the
for
question
having
of
me.
when it'll be in effect, and I just want to make sure that you understand, like, this is part of the rules and regs. We have the telehealth section left to do, and then the code of ethics on professional conduct, which is already written, but telehealth is not. And then we kind of have to go through it one more time of like formatting and kind of checking to make sure everything that we did at the very beginning is updated and everything. My goal is really like October-ish to have it kind of completed, submitted to the board, and then from there that process goes. So I know you're getting a lot of questions of when can we do dry needling, when can we do, because I'm getting them, so I know you're getting them. But like that's the process, and we are working every month like to do this. So I don't really have an answer, but I just can tell people the process.
No, it's great. And thank you for having me on here. This has been so helpful, and you guys are doing so amazing with all the process towards getting approved. So I thank you.
Okay, great, thanks. So do y'all need a quick minute? I know we only have an hour left, but we do have some other agenda items to go through. And Marie and Kristen, y'all are welcome to stay. We're not kicking y'all out, but I just know that that was y'all's purpose, but you are definitely welcome to stay.
Maybe we can take a 5-minute break, Darby.
Okay. Cool. We'll be back at 12:06.
Thank you, ma'am.
Finish the agenda. Brenda, do you think I'm crazy to think we'll get this done by the time we're out of office?
I'm liking it. Like, well, because when you said like we have this part, it hit me that it's not like it's usually been like we have this part. Like we're actually getting closer.
Yeah, I mean, I meant to, so, last time I had sent a, draft of the OTA supervision to Ingrid. And she didn't realize that I had done it. And so I wanted to format the version of the rules and regs that we have, but I wanted to compare it first or format it first. I don't know which, but I didn't get a chance to do it because I was really working on this and this took way longer than I thought. But I still want to do that. And then the next section, which is telehealth, I'm going to try to do a draft like this because I just feel like it's so much easier than starting from scratch.
Yeah. This is again much appreciative that you do like give it to us in this format. It's so much easier to.
Yeah, I mean, it's always easier to edit than to start from scratch, especially when you have a group of 9 people, you know, and just really comparing what all the other states have and kind of looking and really it's helpful, you know, when y'all come after you've looked at the other states and stuff, because then you have like a reference of like, okay, you know, we don't have to go through all that. Like it just takes so much time. So I'm trying to get it to a point where we can submit before we're out of here. And then, you know, what happens, happens, but at least we met our goals. I mean, I know that it'll get done after, but all right, is everybody back? So, Dr. Van, are you okay if we get started? I don't know that he's back and he is the next item on the agenda. Dr. Van?
Give me a second, Darby, I'll get him.
Okay, thanks.
He should be back now, Darby.
Okay, thank you.
You're welcome.
Okay, Dr. Van?
Can you hear me?
Yes, thank you.
Okay, I'm sorry, I was just delayed by one of our directors. I need to talk to them about them. Thank you for being so patient for me.
That's okay. We appreciate you being here. So under old business number 2, I put that on the agenda just because this is the response email regarding the exposure response prevention therapy email. I know that Ingrid had drafted a response that I've seen and she sent to you. I wasn't sure that it got sent out to the person who had originally asked us about this.
I got to be honest and tell you that I don't remember. I apologize. Let me pull it up and see if I can refresh my memory.
Okay.
I have to get the minutes up. Give me a second.
I think the email came from Ingrid. She had drafted the response from the last meeting based on Brenda and Glenn's. They did the prep.
Oh, you mean the issue of the therapy? Okay, I'm pretty sure we sent that letter, but I'll double check and get back to you.
Okay.
We sent that letter.
Okay, just to make sure that got sent, so I can cross it off the list. Okay, so we're going to pop over to new business now. The reappointment for OTAC. Kelly Brandon, congrats to you because you were informed by Dr. Van that your appointment was renewed.
Thank you.
Thank you for serving.
Yes, We're so glad. And then I'm not sure what the status is for Carolyn. Did you agree to do another term? Okay, did you submit a letter stating that you would like to continue your term?
No, I have not done that.
Okay.
Sorry,
so-
I didn't realize I needed to.
No, I'll send you an email that kind of talks to you about that. So I kind of, because I don't know, I kind of lost track of it at the
You may have sent it, but I've gotten 1,000 emails with
Okay.
field work. And
So
so,
we'll do that so that hopefully that your appointment will be renewed as well, but I just needed to check for that. And then number 2, the post for the upcoming. So hopefully y'all got the email on July 5th that with the email blast asking for stating that there were positions in OTAC available. And so I've gotten about, I think it's about 8-ish emails, it could be more, inquiring about specifics of the position. So that was pretty positive. I've not heard from any OTAs. So if anybody can text people who work in big facilities where you know OTAs work, just say, hey, you know, we're really want to consider some OTAs for this. The applications aren't due till August, so we still have plenty of time. But the other input I wanted to give is that for those of y'all who are still be on the committee, that maybe next time we send out the email blast, that maybe we should include more details. And I'm the one that drafted it with Dr. Van, and I didn't think to put things. And so the stuff that's being asked is, you know, basically I'm sending them what our mission is, and then I'm sending them, most people want to know the time commitment, how often we meet, which I tried to put in there. If it's in person or Zoom, where the meeting's located, and is there any monetary compensation for the meetings? And someone said that, are we still they thought the only thing that we did was do the interviews for new grads. And so just informing people a little bit about what we do, which is my fault, but I just felt like, you know, when we do this again, hopefully I'll send y'all all my notes for future, but I'm excited that we got some inquiries. So there were a couple people interested. Dr. Van, do we have any public comment on that?
Let me double check. Give me a second to pull that up. No public comment at this time.
Okay.
And I'll make sure to spread that to the OTA. Thank you for pointing that out again.
Yeah. I'd also mentioned it to Linda Kelly, but I haven't heard any response from her, but just, you know, to think about it and let us know. But yeah. Okay, so the next item is the appointment for OTAC for our representative for the Compact Commission. So I don't know if y'all heard Dr. Van mention this earlier. So the board appointed Dr. Van to be the commissioner of the OT Compact. I don't know if you wanted to say anything. I know that you included information for us to look at on the cloud share, Dr. Van, if you need us to go to that real quick.
No, I think the key is that the people from the commission wanted somebody with authority on the board, not necessarily from the advisory committee. And that's why, and some experience in the compact. So that's how they ended up sending me, because I serve as a commissioner for the medical compact, and now I'll serve as a commissioner for them. But as I said earlier, I view myself as a conduit for the information that you want to give them, or that they give me. And again, you know, perfect example of, I've had problems today. Miss Amanda had a survey to take, and our safety don't allow her surveys mechanism. So I'm having to fix our security issues so I can respond to her survey. But I'll keep you all posted on what we do. It's not that I wanted to do anything, except she asked for somebody with board level authority, and none of the board members want. I tried very hard to get our lay member of the board to do it, but nobody else wanted to do it, so it fell to me.
Well, we appreciate it, and I'm excited. I was not under the, I was under the impression that it had to be an OT, so, but, you know, like you said, you have much more authority, so that should definitely work to our advantage. Do we have any public comment for that?
At this point in time, no public comment, ma'am.
Okay, and then the other thing on the agenda was the scripts for OT clients. So it looks like you got an email from Amy at Abilities. It's I think it's the very last page of the cloud share.
This one?
Yeah, it looks like it went to, nope, no, that was the exposure response therapy one that we asked about earlier. Very last page.
Trying to get to it. Give me a minute.
Yep, it takes a while. It's 45 pages.
This is this, okay.
I can read it to people while we're waiting if it's not
This
there.
one?
Yes. Saying our OT scripts required for patients each year or every third year. We're currently getting them prior to the evaluation and yearly, but it's very time consuming and just wanted to make sure that we are doing it correctly. I could not find it written in the literature that I read through. So I didn't know if you wanted to respond, you want us to draft a response. It's my understanding, and you know, obviously I want everyone that it's not specified in our rules and regs, but it's really it's really left up to the payer.
I really think it needs to be up to anytime modalities change, things change. I mean, you know, I'm concerned that if we're doing this for 3 years without a script, I don't want to tell them they can't. I want to tell them that it has to be reflective of the unique conditions and the changes in the patient and the situation as it presents itself. I don't think you can say any hard and fast rule, because you may have to change it in 6 months. And we mean a prescription for OT when you say scripts, right?
Correct, like a prescription for, like, you know, generally we get a prescription, and we've talked about this in the past, like it generally says like evaluate and treat.
Right.
And there's nothing really in the rules except, and I can look it up, and I think it's important to put that in the email, because so many people don't know and don't do this, that when we get the script, we're also supposed to provide, I don't know exactly the wording, but basically an updated status of the patient. I can find that, but it doesn't specifically say how long the script is good for.
Well, and again, I think that should be left up to the individuals involved, because, you know, again, maybe nothing's ever going to change with this patient and you're going to continue to do the same thing. That's one thing. But again, I think if the situation of the patient changes, I mean, I think you have to have that updated to reflect the new situation with the patient. And I would hope that you all would be telling the physician who gave you the order that the situation has changed.
Right.
Isn't that what your conferences are supposed to do?
Yeah, I mean, generally speaking, and I mean, everyone's obviously welcome to chime in here. Like, I generally get them every year, but it is a process, like she's saying, it's time consuming, but I update the physician and ask, either let them know that the patient's been discharged or ask for a script to continue with the new goals. But basically, I guess with the way that the rules are written, like you could treat a child or a patient for life and never really get a new script unless the payer source is asking for it, right? I mean, what is everyone else understanding? I'm trying to look it up in the rules.
I don't know if it ever says anywhere, but I always got mine yearly just because I thought that was what prescriptions were good for 1 year. So that's what I always did.
But why did we think that?
Again,
That's a
I
good
think,
question, but that's what I always thought too.
well, and again, I think you guys are expressing what I'm trying to express. You know, certainly if things don't change in a year, do we need to continue with occupational therapy? Or there's progress being made, but not fast enough. I I mean, when do we say this is not going to work and we have to do something else? And I do think it's reasonable to say you have to reflect the uniqueness of the situation.
Yeah,
See, in my mind, I mean, Amy, obviously she's an outpatient. But you know, in the school system, you might see kids who are like, for years until they graduate because they're so delayed, and you're just helping them adjust every year to whatever the requirements are. So,
Are you helping them to adjust to changing requirements?
yeah, like adapting their new classroom or things like that, or you know, maybe they can't keep up with the other kids and their playground requirements need to be, you know, I don't know. There's just all kinds of things.
Well, so
that-
you're telling me that every year the situation changes because of the new grade, the new way things do in a different class.
it could, for sure.
It could.
Yeah.
So that I think, again, I think the thing to reflect is when there's change in the way you're going to do things, probably you ought to update the physician and get an updated prescription. When there's no change over time and there's no hope for any change, you should update the physician and say things are not changing. Do you want to continue? And maybe the physician does want to continue even though there's no change. But at least you all are communicating what you all are actually seeing and reflecting in the work that you are doing, so that the person who's ordering is continue to see value in it.
Yeah, I mean, most of the time in my case, and I don't know if it's because it's pediatrics, like the physician defaults to me. Like they'll
Well, but
say,
he's expecting you to tell him something, right?
right, like, okay, like I'm fine if like you feel like you can make more changes, or you know, they have more progress to make, like, you know, so it's definitely a collaborative effort. And that's kind of why I keep it every year too, but I cannot find it in.
I don't think there is anything, and I think it should be individualized. I really do.
It's not in our rules, so I guess what Dr. Van is saying is, though not specified in our rules, it's the board recommendation that you maintain communication with the physician when as appropriate and as changes to the client.
There's
As
something,
the client
yeah, it's not, I was just trying to find in the rules where it says something about when you request for it, that you're updating them. So like to include that in the email of like, you need to continue per our rules, like that ongoing communication with the physician. I'll see if I can find it, but basically we'll draft a response to this, trying to include these statements with the that we're discussing. And I'll see if I can find the I know it doesn't specify how often, but it says something about it because it talks about sending the physician updated information. So I guess even if they don't get the prescription, they still need to be in contact and communicate, like you're saying, the uniqueness of the situation or the changes of progress of the patient. Yeah. Okay, so basically we have like, it should be reflective of the uniqueness of the situation or the individual.
Response to therapy.
Right, their response to therapy, progress, if there's no change, if they wish to continue, and on an individualized basis, and to maintain communication with the physician or the referring physician or the referral source. I mean, I'm just trying to, what I don't want to happen is like just say this and then people be like, oh, okay, I have one and I don't ever have to do anything again. You know what I mean? Like, I just don't want to send that message. So all these points are important to include.
And I don't think you're sending that message. I really don't.
Okay, yeah, well, if we say this, but if we just say like the rules don't specify, so Yeah,
And then if you want to go ahead and make a note next time to add some changes to the rules to reflect what you just said, that's fine with me too. I mean, the key is whoever has given you the order needs to know if it needs to change, continue, or be abandoned because there's been no successful change in the patient's condition.
And Darby, we do, like you said, we do already have language talking about the need to maintain communication with the referring source.
yeah. Right. I remember us going through the rules and seeing that, and I just don't know where it is, but I'll find it later. I don't want to waste everybody's time. Okay, so we'll draft a response to this, Dr. Van.
Send it to me and we'll get it
Okay.
off back to Miss Amy. Include Miss Amy's email with me so I know where to send it to.
Yeah. I will.
Okay.
I guess I need to. How long do we have access to this cloud share? Does anybody know? I feel like I've tried to look at stuff before and couldn't.
What do you mean, how long do you have access to it?
Like, when we get out of this meeting and I click on this link to the cloud share, can I still access this email again?
Yes. If it's on the cloud share, it stays there. You can look at it. I just, let me say this. Jacinta, we taking it off the cloud share?
They may just to keep the storage to a minimum, they may drop it after a certain period of time, but I don't know. Tracy may know that.
Yeah, I feel like I've gone back to look for stuff in a cloud share and the only like recent one popped up, and then after a while, like nothing popped up. So I think you're right, Patricia, but
Yeah.
I just wrote everything down just in case
Yeah.
I can't.
But
access.
also you can go back to the recordings of all of the meetings and anything we shared on the screen said is all there for you to see as well.
Yeah. That was a little torturous listening to the last meeting right after. I didn't say anything, but I knew like I had written stuff about it and I was like, oh my gosh, like, ah, but it was good. It was fine. Yeah. Okay. All right. So
And also, you know, the transcript function too, right, Darby?
the transcript, I'm sorry, what?
There's a transcript function on YouTube too. You can read it instead of having to watch it in real time.
Oh, yeah, no, I didn't know that. I was actually on the plane coming back from.
Oh, okay. Yeah,
And I was
I use that sometimes too, just to speed through.
Yeah, that's probably much smarter. Ingrid might have done that too. I know she goes back sometimes because we can't remember who like made motions and who seconded it. And I'm like, okay, I'll have to look it up. That would be helpful. I plugged in my earphones and did it on the plane. Okay, so we have a few extra minutes and I just,
Darby, do you need to get public comment for this?
oh yeah, I'm sorry. Thank you, Ingrid. Do we have any public comments regarding this email?
No, ma'am, none at all at this time.
Okay. Okay, so getting back to the question of, I don't know if y'all heard what kind of when we came back from the break, just to kind of give us some perspective of the rules and regs. As far as I know, the sections that we have left are, we have to do telehealth. So we haven't done that section because we were looking into that way before COVID and we never did anything. And then now, obviously, that's all changed. And then the physical agent modality thing, and most states' rules and regs, it's just simply like listed in the state's definition of OT. And I'll give y'all some samples of that for the next meeting. But like it has to be in there, and then we have to figure out where to put the dry needling because it is technically the only physical agent modality that we're really reviewing, but because it's so different. And then that last section of the rules and regs of that we haven't done, which is subchapter C, the unauthorized practice, prohibitions, and causes for administrative action. We don't have technically like a code of ethics. Like, is that something, since we're going to be requiring that y'all feel like we need, or is it kind of embedded in here throughout? Like, it's just a question that I kind of have.
I thought we always referred to the AOTA for code of ethics throughout the document.
Yes,
I think we do.
yeah, okay.
We definitely don't want to rewrite those.
No, and it's just, well, it's just a section of the rules that I noticed in other states that I put a note for us, like, because it's a separate section. I'm not asking us to do more work and create another section. I just want y'all to be aware.
Well, I think we've evolved to a certain language, and Pat can correct me if I'm wrong. It used to be ethics, then it was jurisprudence, and then on the advice of our outside counsels, it's became law and rules. So basically, we have a law and rules course that is the most important thing for licensed Louisiana OTs and OTAs to take. And again, I think that's where, we kind of get lost in the language. And like I said, I don't think it's so much, we expect you all to follow the law and rules in Louisiana. And I don't think you'll have any trouble if you adhere to AOTAs, but there are going to be some things that are beyond AOTAs or ethics rules that are in our laws and rules. So understand, I think we're evolving away from the ethics courses or jurisprudence courses and calling them law and rules specific to your licensing class. And I just want to make that comment about ethics in general.
Okay.
Darby, there were a few other areas that we had identified during this process that I just want to bring up that we still have to revisit. First is use of the title of doctor.
Mhm.
Another is licensing of foreign trained therapists.
Yep, okay.
Another is supervision of non-licensed personnel like aides and techs.
And was it Patricia or somebody gonna get back to us about how, like, I remember there being some discussion at the last meeting. Again, I wasn't there, but it was something about like who does the supervision of that, and they were gonna look at how like the PAs do it maybe or something. Am I doing
I don't remember promising that, but I'm sure I did, and I will write it down and make sure I do it for next time.
What, am I making that up, guys? Or like, there was something where,
I recall that as well, Darby.
okay, I thought so, like, and yeah, I kind of remember being confused about that.
That was also an area where we wondered if we should look at some more other different states, but we do have some states wording already that we could use as a template, like Kentucky.
Yeah, okay, that's what I remember in the minutes. It said that it was going to be an other states project. But
Yeah.
I'm sure I did say I would do it, and I will this time, I promise.
Okay,
So that's another area I hate to keep lumping on areas, but that was another one we still had to get back to. And then finally, I wrote in here, temporary license section needs work. We said that back in March. We had already reviewed the temporary license section like last year, but then in March, we felt like we need to go back to that. I don't remember what our issues were, but I've got that written down.
no, I have some notes on that too, like how long do they last, when and if renewed, yeah. So, and I guess like my question to Patricia is like, just to kind of help me, my goal is to kind of have these like to y'all before December, which is when Brenda and I exit left. But we said like this is going to be our goal. So once we kind of go through and then address, like, we still have the areas that we have nothing, like telehealth, and we have that one section that we haven't looked at all. And then the 4 areas that Ingrid mentioned, there might be more, and kind of do some very simplistic formatting. Like, what is the process after that? Do we just hand it off to you, Patricia? Do we work with you? Do we, like, is there anything we can do to make it easier for you or to make it quicker?
Well, so once you all have approved the top to bottom, A to Z, everything's been approved, and you have what you want to send to the board. This is our recommendation. The board will put it on the agenda for the next meeting. They will review it. One of you all would probably like to possibly be there, if, you know, just to answer any questions, if any come up or something like that, or just to represent the committee that, yeah, this is us, and take a bow, frankly, for all the work you put into it and how hard, you know, how much time y'all have put into it. I would strongly encourage you to do that. And then they will vote. Do they agree and direct us to promulgate these as proposed rules? And we can usually, if they have some minor little things on the fly, we can do it in that meeting. We don't necessarily go back to you as an advisory committee and say, hey, they wanted to change the to and or whatever. If they have a real problem with a substantive provision that we know you all are invested in, then we might ask them to approve everything but that, and then we'll come back to you and see what we could do with that. But the stepwise process then would be, if they direct us to start promulgating, then we file a notice of intent, we publish that, we have to have a physical hearing about that just for the rules, and then it goes through an approval process, either through the OLRC or through an AG program, which is what we use to have our occupational license rules reviewed. Then it goes to potential oversight at the legislature. So it's anywhere from a 6 to 9 month process. But from your perspective, it would be to be available to the board for that meeting where we present everything for their approval, to answer any questions or provide any technical assistance. And then if we get pushback in any kind of a hearing or any kind of public comments, once this has been published to the world at large, give technical assistance to us as to what the response should be to any such comments, because we have to show that we considered them and what the response was.
Okay, that's super helpful. And then the document that goes to them, like, we would take out all the things that we crossed out, right? Like, it's presented to you exactly how we want it to be adopted, correct?
So, right, well, it actually, it's for the board's purposes, we'll present them with a clean copy and a marked up copy so that they can see what it used to be and what it will be going forward. And for the next process, it actually depends on who. We have to actually send this to a whole bunch of people after that, and some of them want only what it's going to be if it's adopted, and some of them want a marked up copy. So that's just technical logistics on our end, but for purposes of the first presentation to the board, we will give them both.
Okay, I guess.
And again, we're going to urge them to amend by substitution as opposed to individual amendments that would take a number of times for them to vote on. And if they simply adopt, they can see the difference and amend by substitution, then it's done, it's finished, the whole document goes on. And like Pat said, the people that want to see the changes will get a copy of that, but it's a process that just is dictated by the the APA laws in Louisiana, administrative procedure laws.
Okay, yeah, I mean, I guess part of the big question in my head was like the marked up versus the clean, because we're kind of doing both, and it kind of complicates things, but I know that we need to see what was there before, but good to know. Does anyone else have any questions about this? No. I'm gonna try for the next meeting, which had that screen up and now it's gone, is August 4th, to have a draft for telehealth, and then give y'all like what I did for the PAMs of other states for telehealth. So if y'all can do, just, I know it's a lot of work in between the meetings of just kind of reviewing it so that you can come with a little bit of familiarity just for the purposes of time. I just, I know it's July, it seems like we have a long time, but I kind of feel like we kind of don't. And then we'll tackle like the other sections too. The other thing, Ingrid, if you're keeping a list, is we need to put somewhere in there that these need to be revised every couple years.
Yes, that was another one of the things.
Yeah,
Darby, if you try to get a draft on telehealth, then I'll come with a draft about supervision of unlicensed personnel.
okay, that'd be great.
Should be, I mean, hopefully we could get both of those done at our next meeting.
Okay, yeah, that should be good. That would be amazing. I felt like it was a huge thing to get through dry needling because that was a lot. Like, I don't, it's just the pressure from people of like, when can we do it? When can we do it? And just fortunately, it was a little bit easier because not many states have it in their rules yet. So I only had about 6 states to look at, but okay. So are there any other further questions, comments, public comments?
There are no public comments, ma'am, at this time.
Okay. Anything else? Y'all okay adjourning early? Yep. All righty. Well, the meeting will officially be adjourned at 12:42. Thank you all. Thanks so much for filling in for me last month. I appreciate it.
No problem.
Thanks for all your hard work.
Yep. Thanks to everyone. All right, guys. Y'all have a great weekend.
Bye, everybody.
Bye-bye.